I'm going to correct a little bit. Thanks for the kind introduction as well. I'm going to correct him a little bit in what he said, because I'm not going to actually talk about joint.
Increase the volume.
Put the mic up to your mouth.
You want me to really speak loud?
Yes.
So I'm not really going to speak about joint replacements. What I'm going to speak about today is what is called joint preservation. So mark the words, because it's not really replacement. We're not going to talk about removing the joint and putting it into the bucket. We're going to talk about how do you save the joint. Okay. So that's a conceptual difference in what the introduction was, but that's okay, because that is why I'm here today. This word joint preservation is not something that any of you probably have heard in this room. And if you have, that's a great thing, because that is where we are today. So I do joint preservation surgery for the hip in the entire city. But my lead program is at Tri-City Medical Center, and it is the hip preservation program at Tri-City. But I work at 7 different hospital systems in San Diego. And with that, I'm going to begin my talk. These are my disclosures. I am a consultant for a few industries related to my work. And as I said, as they want sometimes say, either you should have no conflicts or you should have a ton of conflicts. And I think we belong to the second category here. Let me begin by asking a question. Well, before I even ask the question, I want to make sure that you all are able to hear me well and understand me. And you clearly understand that based on my accent and my skin, by now you realize I'm not a Native American. I was born in India. I was trained in India. I was trained in London, England. And then I moved to Philadelphia, and I'm here today in California. I'm a citizen of the United States. I have no idea what my accent is at this point, because I've been in 3 continents, and it is what it is. But as long as you can understand me, I think we're all on the same page. So, let's begin with this simple question. What is hip joint preservation surgery? I don't want you to answer that question, but I want you to look at all these options. And I'm going to walk them through. Is this some sort of a new surface replacement hip arthroplasty? Is it something resurfacing? Because that word comes up a lot in today's world. Is this an arthroscopically performed hip replacement? Today we are so advanced with arthroscopy, I think someday we'll do a brain transplant with arthroscopic intervention. And then, is this a hip replacement performed by some sports surgeons? Or finally, is this a procedure where you restore the joint mechanics, optimize the articulating surfaces with as much cartilage and labral preservation and repair as possible? Just listen to the options, don't answer the question yet, because I assure you, when I'm done with my talk, you all are going to answer all my questions. The door is locked, you can't escape anyways. Okay, I was initially told this is going to be 30 and below, but hey, you know what? Everybody in terms of age is here, so let's talk and move into some few questions. All I'm going to do is I'm not going to bore you with lots of slides. I'm going to tell you lots of stories, that's all. Because you can only remember stories. You don't remember a lot of material. 31-year-old active male with hip pain, limited motion, athletic, loves to ski, works as an IT consultant. And that X-ray. I know you're not radiologists or physicians, but that X-ray is clearly not a normal looking X-ray. So what are his options? His options, does he get a traditional total hip replacement arthroplasty? Does he get what is nowadays a cool thing, the anterior approach hip? Or does he get this another cool thing called superpath hip? Does he get a hip preservation surgery? Does he get a bunch of epidural injections in his hip? Or is it just too sad? He's got to live with this forever. Let's leave the question here again. Let's go to a 36-year-old anesthesiologist. Pain in the left hip, inability to sit for long, and not responding to conservative treatment. Are we going to give hip injections to this lady? Do a total hip arthroplasty? Do what is called a hemiarthroplasty, or replace just half of the hip? Do a core decompression? Or do a joint preservation? Well, let's go back to same option 6. Just too sad for her. She's got to live like this forever. I'm going to take you down history of orthopedics because that's very relevant and very important. Orthopedics has been around since 1741. Nicholas Andre described orthopedic surgery in 1741 as the art and science of correcting the deformity in a child. And in fact, when orthopedics was described, and even today, the word orthopedic surgeon means a child specialist, for those of you who do not know that. Orthos, pedos. Pedos is child. So in fact, if you go to adult orthopedic surgeons, and I'm one of them, I do treat children and adults both, we have to say I'm an adult orthopedic surgeon, because you cannot say I'm a pediatric orthopedic surgeon. You can't use the word child twice in the same sentence. So it has been around for a while. That's Achilles treating Patroclus in 1000 BC. This is a shoulder dislocation been reduced in 700 BC. And you go looking at that thinking, wow, I'm so happy. It doesn't happen these days. This was another way of reducing joint dislocations. And I'm happy you have that little chuckle coming out because remember, we're smiling and laughing about something today in 2014, but this was the state of the art at some point in time. So, for some of you, when you were young and had a fracture, maybe you were admitted in a hospital and put on a traction. Just until about 20 years ago, patients with fractures were admitted in hospitals for several days, sometimes several weeks, and put on tractions in the hospital. But now, since I crossed the pond and came here in 2002, I have not, and I've been in Philadelphia, one of the busiest hospitals, and then in California. In the last 12 years, I've not treated a single patient with traction. Where am I going with this? It is a very evolving specialty. Just like medicine, we continue to evolve radically all the time. There's lots of dogmas that change in orthopedics. You can believe that Hugh Owen Thomas, who was the father of orthopedic surgery until his era, said, when you break something, you got to immobilize, immobilize, immobilize. People were putting a cast, body jackets, plasters all over the body, and kept like that for months and sometimes years to heal. And then came Lucas Champion, who said, life is motion, motion is life. You cannot keep someone in a cast forever. You got to start moving the joint. Thomas said he's crazy, of course, because he was the professor. But then, today, tell me any of you who have had friends or yourself with broken bones. You go in, you get it fixed, and you move on. You want mobility, function, quality of life. Let me walk you through some more history, since he introduced the topic as hip replacement. Until 1960, if you had arthritis of the hip, you were resigned to sitting on the porch for the rest of your life. And you were considered disabled. Until Sir John Charnley in England, Wrightington, described an operation where he said, what if you put a metal ball and a plastic socket and cut the arthritis away and let that patient walk? They officially declared him crazy. They did not allow him to come to their meetings for several years. And today, he's knighted as Sir John Charnley. There is a stamp in England in his name. Wrightington Hospital has a statue in front of it with his figure there. And in the United States, we do 800,000 total hip replacements every year, which is considered the standard of care. So it's important to get and flow with me on this in terms of where we are with history. Look at scoliosis surgery. It is crazy to put screws into someone's spine, especially when the spinal cord is just a few millimeters away. But that's the standard of care today. We've come a long way. Many of you sitting here have had rotator cuff tears. Some of you had arthroscopy before. until 1991, slap tear was not even described in medicine. And today in 2014, shoulder arthroscopy and slap repair is the highest billed procedure in the United States for shoulders. So we do change a lot. And why I have your attention here today, I'm going to introduce a topic which you've not heard before. And that's why I'm building this history for you, because that's how change happens in medicine. What we did not know until about 20 years ago was the fact that arthritis of the hip joint is not a primary condition. What I want to say is, until then we thought that if there is an arthritis happening in the hip, it will happen no matter what. You cannot do anything to change it. But in the last 20 years, thanks to a lot of work from across the pond in Switzerland, that I did my fellowship, we have come to know that arthritis of the hip is not a primary condition. 90% of arthritis of the hip is preceded by a condition called femoral acetabular impingement. And when someone has symptomatic femoral acetabular impingement, if left untreated, they will 100% progress to arthritis of the hip. So if you have to take one message out from this room today, you want to understand what is this pre-arthritic condition of the hip. Because there may be several people, even sitting in this room, who may be having an impingement today. So, I'm going to show you a slide and a video of one of my patients from last year. With his permission, he wants me to take his name. He's Dennis Hamlin, and he lives in South San Diego. He's the CEO of his company. He's 56 years old. Very athletic as a young person, loved to ski. At 56, he had severe hip pain for 3 years. He went and took 5 opinions in the city. In fact, the chief of orthopedics at Sharp was his personal friend from school days. And Peter Hansen referred Dennis to me to see if hopefully we can do something for Dennis, other than a hip replacement. Because Dennis did not want a hip replacement. He did not want to lose the ability to his full function. And Dennis underwent hip preservation surgery. And this is Dennis, 10 and a half weeks following surgery, skiing on the slopes of Utah. And he sent me this video to share with you. Let me see if it plays. Nothing great about the video other than the fact that at 10 and a half weeks, this man who was in pain for 3 years and barely could walk without a limp is skiing down the slopes of Utah. And is this a miracle or what is this? So let's walk you through what this is, okay? The layout of my talk is going to be, what is this hip impingement? How can the hip joint be preserved? How do you diagnose this? Can any of you diagnose this? I'm probably going to teach you today how do you diagnose it on yourself and some of your family members. Understand and educate others. You are going to be my medium of educating the rest of the community. So focus your attention. And then, of course, I run this program at Tri-City Hospital. We started the program a year ago, and it is run at Tri-City Hospital as a hip preservation program. If you pick up any magazine or journal for sports today, you'll hear somebody's going through a labral repair. Somebody's going through hip surgery. What is this hip impingement? The hip joint is a ball and socket joint. The socket is like a soup bowl, and the ball is like a soccer ball. There is a motion between the ball and the socket. And just like we take our car for alignment of its wheels, because of course, if one of the wheels is not aligned and the other 3 are, you're going to have a wear and tear of all 4 of them. Similarly, if the ball and socket are not aligned, if there's an abutment of motion between the 2, you are going to get what is called impingement. A lot of conditions can cause impingement, but remember, 90% of patients who get arthritis have some form of impingement. That's a big number. It's not 9%, it's 90%. Which motion of the hip causes risk? This motion. Flexion, adduction, internal rotation. This motion of the hip causes the worst possible impingement position. And early aggressive sports in an early age. My son started playing basketball at 6. Peer pressure, a lot of peer pressure in today's society. I can tell you, there are some of you here who look as if you're in their 5th and 6th decade, and think back and see how active you used to be in your 10s and 20s. Look at the generation today, where they are. They have suddenly, in 10 years, gone 500% in terms of their activities between the age of 6 and 15. That's why the recipe for impingement starts early today. Many of my patients are basketball players, soccer players, lacrosse, ballet dancers. I will talk about it. I'm sure you can identify all these sports on the screen there. Look at the position of the hip in all these sports. These are active, athletic, healthy individuals, but putting their position of the hip at risk by doing some sporting activities. And some of you in this room may say, well, I never did that. So, I never probably put my hip at risk at all. Well, you sure did. So, every day, you do put your hip in flexion, adduction, internal rotation position, hopefully once a day. So, so yes, nobody is deprived of the position at risk. What are the sports that I deal with? I deal with patients who have had these sports in their younger years. Not necessarily actively in these sports, but you could have been a basketball player 20 years ago. And you have done all that and caused axial compression of your femoral head and led to this problem. Deep squatting activities like powerlifting can cause a risk for impingement. Now that we have outlined what impingement is, which is abnormal motion of the ball in the socket, let's go very systematically and figure out if there is an abnormal motion on this ball or the socket. It could be either a problem with the socket, either a problem with the ball, or both. That's pretty simple. So if it's a problem with the socket, it's called a pincer. If it's a problem with the ball, it's called a cant. And if it's a problem on both sides, it's a mixed impingement. So let's go through, again, very systematically on a flash video as to what exactly happens in a pincer impingement. By nature, most women have pincer impingements. So if you have a 25 to 45-year-old woman with a hip pain, more likely than not, she has a pincer impingement because the nature of the socket in females is deeper than men. So remember that if there is a family member, friend, 25 to 45, complaining of hip pain, particularly when she's getting up, she is not psychotic or she is not having issues, she probably has a pincer impingement, and that's the early stage of her arthritis that is starting. Now look at this closely. The yellow, the bright yellow is the normal socket. This bad yellow color is the deep abnormal socket. This red color here is a cartilage around the hip joint called the labrum. Okay? And this blue ball is the femoral head. Now I'm going to start a video to show you what happens in an abnormally deep socket. So that's a pincer. A deep socket acts like a pinching thing. It pinches the ball. And look at the motion now. In these patients, over a period of time, the edge of the socket will dig into the ball and the head-neck junction, tear the entire cartilage here, and start causing problems of impingement and arthritis. I know I was not supposed to show blood pictures, but I'm a surgeon. What else can I do? I open the human body every day. So I think I'm going to, and a picture is more than 1,000 words. Okay? So let me run these stories by you. This poor female was 21 years old, is 21 years old when I did the surgery. Was in hip pain for 3 years. a ballet dancer. And all they told her was, because most of these conditions are not picked up by normal physicians. They were not trained to look at this. Radiologists missed this condition as well. So 3 years she went through physical therapy. And physical therapy was killing her. And eventually, somehow, she came down to me. And I treated her. And I'm going to show you what was going on in her hip. She had a true bad pincer lesion. Okay? I want you to focus on this part of the femoral head. You remember the diagram that I showed you, the illustration. Now look at this part. And this 21-year-old was not faking it. Okay? So let's show you that.
Aren't you glad you're showing us this before lunch?
Do you see that? Do you see the true mechanical abutment? Do you see that there was no way someone with physical therapy could force that patient to have more motion? Because you know what? If there's something stuck in the door, like a torn piece of carpet, you can't get more motion there. Okay? So this was a genuine case. She's 5 years post-op, 100%. No pain. She's not going to get arthritis for the next 40 years. Okay? Let's go on to the next. So I hope you understand what is a pincer lesion. Now let's go on to,
Excuse me,
yes,
what was performed there then?
I will tell you that. Yeah, and I'll show you the whole presentation and then we'll take questions. So now, let's go on to the next situation. Again, this yellow is the normal socket, red is the cartilage around the hip, and the blue is the ball. But look at the ball. That ball is not a perfect sphere. Okay? I have put a 3 millimeter, just a 3 millimeter bump in the front of the ball. Okay? Now let's see what this ball goes through in its range of motion. That's a cam lesion. It comes from the Home Depot word cam, which is not a perfect circle. See how that small bump gets into the hip, tears the labrum, then starts escaping more and more inside the socket and kills the cartilage. Okay? Boys have cam lesions. So if you have a male patient between the age of 15 to 35, basketball player, very active, very athletic, and restricted motion, more likely than not has a cam lesion. And I'll show you a basketball kid, 21-year-old, 6 foot 2 inches tall, hip pain for 2 years. And the coach was telling him to obviously suck it up. So look at this kid. Look at this part of his femoral head. Okay, concentrate here while I run the video. And I'm going to dislocate the hip and show you what happened inside. See how that bump is tearing off the cartilage here? And then when you open the socket, in this 21-year-old, see the destruction of cartilage inside. He's just 21. I fixed the entire labrum, glued the cartilage, and we'll talk about what was done. What I want you to understand right now is the pathology. We'll talk about treatment. So now all of you understand what a cam lesion is? Okay. A mixed impingement is nothing but both sides get affected. And eventually every lesion becomes a mixed impingement if left untreated. So what do I normally get? Most patients that come to me are mixed because they're not diagnosed for several years, sometimes several decades. Okay? How do we diagnose this? A very simple test. Very simple test. In fact, if we finish early, I'm going to have 5 volunteers come on who somewhat have some sort of a hip pain. And I will show you how to diagnose it. So it's very simple. The one motion of the hip that gets affected is internal rotation. Okay? Normally, we are supposed to have 40 degrees of internal rotation, everybody. When you start getting less than 30, you are already going into joint restriction. Most patients who come to me have either 10 or 5. Very simple test, internal rotation. When you're doing internal rotation, again, see if you're getting discomfort in that hip. Now that's the first part of the test, because if your internal rotation is restricted, then you do the next arc of motion, which is flexion, adduction, and internal rotation. And someone has to do it on you, unfortunately, because When you do that, if you get that catching pain in front of the hip, you already have labral tear. You already have it. And you know, most of you will think, why would I do that position? But this is a physical exam. So if somebody in your house, family, friend has hip pain, at least look at their motion. If they are less than 30 degrees, they're already impinging. Okay? So simple test. So what do I do in my clinic first? Nothing fancy at all. I actually examine the patient, believe it or not. So examine the patient. Find out what is the restriction of motion. And in females who have a global pincer, which is, I explained to you, females sometimes have deep sockets, they will not be able to even extend and externally rotate the joint. So sometimes you have to bring them to the edge of the bed and do that test. And then we do some x-rays, special x-rays to look at it. Nothing really fancy, just a plain x-ray of the pelvis that looks like this. And then a lateral of that hip that looks like that. What am I looking for? We're really looking for that bump in front of the hip. Okay? This is not a new condition. These are the femurs from the Egyptian mummies. And impingement, I'm going to show you what impingement looked like, was there even in that era. The eye does not see what the mind does not know. So that's a normal offset. See that? That's how a normal femur is supposed to look like. See the cam lesion? That's the bump. Okay? So it existed even back in the day. That's how the normal offset is supposed to look like. That's a lack of offset. Lack of offset, early cam lesion, impingement. And we do some radiographic measurement. See, again in this case, I mean, of course, we are physicians, we have to objectively measure things and then you have to treat them, but see that this is a normal hip and the angle is normal, which is always less than 50, and see how this bump changes the angle to about 70, 80, or sometimes occasionally going to 90. I'm going to show you one more video, a flash, of how a small bump in front of the hip restricts your internal rotation. That's why I showed you the internal rotation test. This is the arc of motion of a normal hip. You're looking as if you're looking at the hip from above, as if you're cut through the pelvis, okay? And see if I throw a 3 millimeter bump on that hip, what happens to the arc of motion. Some of you who understand mechanics will understand that the closer you are to the cora, or the center of the hinge, the more restriction of motion happens. The further away, the less restriction. So the hip joint, unfortunately, is the cora, or the center of rotation. If there is a bump right at the center, it will restrict tremendously the arc of motion. Okay? So I'm going to now show you some stories. The stories of patients, because that's how we realize. This is his young 17-year-old ballet dancer who went to Boston, Philadelphia, and Colorado, 3 of the big hip centers for opinions, and ended up eventually in San Diego. I'm not proud that she decided to come to San Diego. It was more of a headache because, you know, when you have such high flyers who go to the whole country for opinions and then decide to come to you, it's more of a responsibility and more demand on the patient. But anyways, this is a pincer lesion in a 16-year-old. 16. And the only reason she came to me, I believe, was because I was trained both in children and adults. She's done extremely well, 4 years post-op, 100%. But I'm going to show you how cartilage looks in young patients and how things can be reshaped. Okay? And I want you to understand that when you look at all these surgeries, remember, there is no metal, there is no plastic. It's your own natural hip joint that is preserved, restructured, resculpted, and put back inside. Okay? All right, so let's walk through this patient. This is a very subtle cam lesion. That was not her biggest problem, but that's a subtle cam. And that's the cam from the other side. We use these jigs. I created some of these jigs for understanding the sphericity of the femoral head during surgery. And then you recognize that this is the point where the offset changes. It's not allowing that thing to slide down back. And then you start doing the reshaping process. So you start taking off the abnormal bone, And this is the final product. Beautifully resculpted femoral head. There is no metal there. There is no plastic. It's a preservation. If you don't mind, I'll take questions right after this. Then, she had a big pincer as well. Now the trick to doing the pincer surgery is, and look at the quality. In fact, I'm just going back for you to look at the quality of the cartilage. This is a 16-year-old's cartilage. Pristine, shiny, beautiful. There's nothing wrong with the cartilage. If impingement is removed, arthritis cannot happen for 40 years in this patient, just because we diagnosed it early. I would hope that she will not have arthritis at least till she's 70, and she's 16 right now, so that gives her a ton of time. Look at how the labrum looks in a young patient, 16-year-old. You take down the excessive rim, it is just sculpturing. You take a high-speed burr that rotates at 60,000 RPM, and then you slowly sculpture and trim it back. Okay? You take the rim back, reattach the cartilage back to that edge with suture anchors. And all this is tacked back down, so the hip is completely reconstructed. You do have to put 2 screws to put a piece of bone back there. That's the only implant in the surgery. These screws often come out about 6 months post-op, so rest of the life, there's no implant inside the hip. Let's go to Dennis's case. I told you already his story. And I'll show you, the reason I showed the first case before was I wanted you to compare what cartilage looks like in a 16-year-old. I'll show you some different age groups as we move along. How are we doing the time? Anybody's watching the time?
You got about
I'm allowed to speak till what time? 15 more minutes?
15.
Okay, all right. That's how Dennis's cartilage looked like in the area of the cam lesion. Remember those videos? The cam was going inside and getting badly crunched up. Same thing, reshaping. This is the final product. 56-year-old Dennis has this hip at this point. Okay. Even if he wanted it, something to last even 5 years, I would hope that this lasts at least 20 years. And then I refixed his entire labrum, and we sealed down the cartilage. 59-year-old from Rancho Santa Fe, horseback riding guy, CEO of a company, has to do his horseback riding. He said, I cannot stop this. That's going to kill my life. I just cannot stop it. So did not want a hip replacement. And therefore, but I had a pretty bad arthritis. So we did something more innovative. In fact, this is the first ever case done in the United States. So I want to show this to you. We used a product from Zimmer, which is cartilage, and I'll show you what happened in this case. So see, pretty fairly advanced arthritis. The ball looks like a pear-shaped structure at this point. So I had to work on the ball, reshape the ball, which I did. But see that he had a pretty bad defect in cartilage on the femoral head. And so we use this product. These are live chondrocytes. These are obtained from young patients who have died because of a car accident or something, usually between the age of 13 to 18. And they are maintained alive. So, and we use the chondrocytes, and this was transplanted into Dennis's acetabulum and femoral head. Dennis is about 7 weeks post-op right now. Preoperatively, his motion on the right hip, because of his severe arthritis, was 0 to 40 degrees, that's all. And he had no rotations. I saw him 3 days ago. He is from 0 to 110 right now and has an arc of 50 degrees of motion, which is wonderful considering where he started off. Let's go to this patient, 20 years old. I'm going to do just 2 more minutes and cut it off because I want you guys to ask questions. 20 years old, this young lady from La Mesa had 3 arthroscopy surgeries for her hip, 3 performed by the same surgeon in San Diego, and continued to have severe pain, severe pain. This is what had happened during arthroscopy. A chunk of her femoral head cartilage had been removed inadvertently, and the real cam lesion, which is sitting here, was really not addressed at all. Now, all of your masters in cam lesions, you all know what I'm talking about. So I had to obviously address the entire cam and really sculpture the femoral head. And there was a defect in the femoral head here, which was sealed and treated as well. Emily is now 2 months post-op. This is her labrum that was chewed up pretty bad. I reconstructed the whole labrum and tagged it down again. So really doing well, no pain, full activities, just in 7 weeks. And this is a 33-year-old female. Again, one arthroscopy surgery before, failed, hip pain. 33 years old female. What do you think it is? Female with 33 years old. Pincer. Good. See, we all can pass the board exam. So, see what the pincer did? Pincer was pinching into the femoral head. And that was a pincer. It was not diagnosed by arthroscopy because the arthroscopy cannot get that deep into that part of the joint. So again, bad cam, reactive cam, bad pincer. All it needed was restructuring, resculptor, reshaping of the head, trim the pincer down, fix the labrum, and that's the smiling Janelle Cafe. She's got 2 young kids. She had been on pain medications for 3 years. She could not breastfeed her young infant because she was on pain meds. And I've never seen her smiling until post-op now. So we can also use this for treating other conditions like hip tumors, because at the end of the day, even patients can get tumors around the hip. That's a bad tumor around the hip, treated with this technique. And this is a 4-year post-op, no recurrence, no implant, no arthritis. So I also talked about the treatment now. Kind of caters based on what you have, but that's really what it is. I think most of you have even understood the concept of treatment here. Just don't start doing it in your garage when you go back. So, a little bit about radiology before I close on this. Clearly, the Germans changed the life of medicine. And I do give credit to that, because unless we had x-rays, nothing would have changed in orthopedics or medicine. 1987, Wilhelm Röntgen describes x-ray in Germany. And then he gets a Nobel Prize, obviously deserved, well-deserved Nobel Prize. And then it crosses the Atlantic and comes to us in Massachusetts. It's interesting that between 1910 and 1930, 300 orthopedic conditions were described, just because we could now see into the human body. And aptly so, x-rays have stayed until today. I mean, you go to a doctor's office with a broken bone, you get an x-ray. There is no question. So the unfortunate thing is, though, that we haven't really built much since 1897 as far as x-rays are concerned. But we've gone a level ahead with CT scans and MRIs. And I'm going to show you the MRI of tomorrow. I work with the German group a lot, and this is going to be the MRI of tomorrow in our country. It's somewhat sad to say that we're still not at the top in terms of some of the technology that happens across the pond. But the standard MRI that we see today is just this. The MRI of tomorrow is a colored biochemical analysis of how much cartilage loss you've got. Today's doctor can just tell you that, hey, you started to get early arthritis. He can't tell you that 33% of your cartilage is gone. I think that's the next level. It's already there. It hasn't come down to us yet. We'll see when, maybe in less than 5 years. And that's how beautiful it's going to look. These images are going to look tomorrow. We do some special MRI scans up in the North County here too for treating our patients, but we haven't gotten to this level yet. Again, my last slide, few slides tell you, is this surgery a resurfacing? No. Is this surgery some cool total hip replacement? No. There is no implant. Don't take the message out of this room that this is some sort of a resurfacing. And this is all that you get, metal, plastic, metal for replacements. Preservation is not replacement. Final take-homes, we've clearly evolved in our understanding of hip mechanics, motion, impingement. Hip impingement is a pre-arthritic condition. It presents in young patients, but also happens in older patients. Imaging is advanced significantly. And remember, joint preservation is certainly possible. It's certainly possible today. We've really advanced a lot to do joint preservation. Now let's go through this. Okay? I want all of you to pick an answer. What is hip preservation surgery? This is a novel type of hip replacement, resurfacing, arthroscopically performed, hip replacement performed by sports surgeons, or number 5. How many for number 5? Good. 31-year-old active male. What would you do for this patient? 4, good. 36-year-old anesthesiologist. The problem that we talked about, what would you offer to this patient? 5, perfect. That's my email address. You can write it down. Don't put it on Facebook or something. Right? You can write it. I'm very communicative with patients. I'll put down my office number only because once you do become my, or somebody does become my patient, they get my cell phone number, right? I wouldn't want my cell phone number to be out there. I'm going to take questions, but my purpose of this topic was to make you understand a new condition. It's not a new condition, but to understand what a pre-arthritic condition of the hip means and what do we do to save the joints. Let's start off with your question. Yes.
I'm kind of hearing that the hip replacement I had with the ball and chain is not the best I could do.
You're not hearing that. What you're hearing is, because probably your doctor who treated you offered you hip replacement, you had crossed the bridge for a hip preservation operation.
Yeah, so I was too bad to have what you do.
That is correct.